Good day everyone, my name is Clarissa. For today's activity, we're going to continue to review the ESR of the SIBAHE, specifically the or the medication management, namely the MM5, MM6, and MM41. Now, the purpose of this activity is for us to be aware under our roles and responsibilities in promoting safety in the administration of high alert medication and look-alike, sound-alike medication, as well as the awareness in the process of medication error reporting. Now, at the end of this presentation, an assessment will be provided as part of your participation. Now, for any clarification or queries, the Academic Affairs, Nursing Education, and Pharmacy Department is delighted to address your concern. Okay, now let's have a quick review on the 20 ESR standards of the SIBAHE, starting with HR5, the process of staff credentialing, MS7, the clinical privileges for medical staff, PC25, handling, use, and administration of blood and blood products, PC26, DVT identification and management, then QM17, the process of correct patient identification, QM18, the process to prevent wrong patient, wrong site, wrong surgery or procedure, AN2, the anesthesia staff having an appropriate qualification, AN15, only qualified staff performing the moderate sedation or the conscious sedation, IPC4, that there is the presence of a committee that supervises the infection control, IPC15, isolation practices, MM5, this is the system for HAMS or high alert medication, MM6, system for LASA or the look-alike, sound-alike medications, then MM41, medication error reporting, LB51, the process that prevents disease transmission by blood transfusion, FMS9, radiation hazard, FMS21, the effective alarm system, FMS22, the fire suppression available in the required area, FMS23, the fire exits are located properly, FMS24, the hospital and its occupants are safe from fire and smoke, and it has something to do also with the no smoking policy. And finally, FMS 32, that the hospital ensures proper maintenance of medical gas system. Medication Management or MM is Chapter 21 of the SIBAHE Manual, consisting of 41 substandards, 3 ESR, we have MM5, MM6, and MM41. Now, medication safety is now becoming the priority in all safety programs because of the magnitude of harm that can caused by wrong medication and wrong dose is of great value. Now, many sentinel events occurring in hospital today are actually medications related or medication related. Now, to eliminate any potential harm that could caused by medications, hospitals need to develop their own medication management system. Now, the processes and activities related to MM or medication management includes staff planning and qualification, staff education, selection and procuring of medication, storage, ordering, preparing and dispensing, administration, monitoring and evaluation, using of evidence-based practice to develop safe medication and management processes, reducing variations, errors, and misuse, and reporting of medication errors. Now, in this chapter, medication management or MM, our focus here is MM5, has something to do with the safety of high alert medication, MM6, the safety of LASA or look-alike, sound-alike medication, and MM41, this is the process for monitoring, identifying, and reporting of significant medication errors. Okay, now moving on to the first ESR under MM or medication management. So the first ESR is medication management number 5 or standard number 5, wherein it states here that the hospital has a system for the safety of high alert medications. And substandard states that there is a written multidisciplinary plan for managing high alert medications and hazardous pharmaceutical chemicals. So this includes identification, location, labeling, storage, dispensing, and administration of HAMS. Another is the hospital identifies an annual updated list of high alert medication and hazardous pharmaceutical chemicals based on its own data and based on the Institute of Safe Medication Practice. Now, the annual updated list contains the controlled and narcotic medication, neuromuscular blockers, chemotherapeutic agents, concentrated electrolytes, antithrombotic medications, insulins, anesthetic medications, investigational drugs, and other medications. Okay, so another standard of the medication management number 5, it states here that the hospital plan for managing high alert medications and hazardous pharmaceutical chemicals is implemented. So this includes improving access to information about high alert medications. So how we can achieve this one: the academic affairs, nursing education in coordination with the pharmacy department. We usually conduct an annual lectures with regards to improving the safety of HAMS, LASA, as well as medication error reporting, including crash cart. Then we also have here limiting access to high alert medications, using auxiliary labels and computerized alerts if available, standardizing the ordering, transcribing, preparation, dispensing, and administration and monitoring of high alert medication. Now let's talk about standardizing. This means that our hospital implements a consistent procedure and protocols with regards to the administration of HAMS. Then we have employing independent double checks. So we have to focus on this one, nurses. So employing independent double checks is necessary because this is a safety strategy used when administering HAMS. Why? Because medication have a narrow margin of safety that even small error can cause serious injury, life-threatening events, and even death. Now, employing independent double check means this is a process in which two qualified healthcare professionals independently verify the key aspects of the medication or the HAMS before it is being administered. So what do we check? What are we going to verify? So we have to verify right patient, right medication, right dose, right route, it could be IV or oral, right time, presence of any allergies, expiration date, the pump setting, if available. This is something to do with the use of the infusion pump. And then finally, the hospital develops and implements standard concentrations for all medications administered by intravenous infusion. Okay, now moving on to the policies and procedure that supports ESR MM5. We have here the title, High Alert Medication Guidelines and Handling. Now, if you notice, every time I'm presenting policies and procedure of our institution, I usually screenshot them because it's easier for us to grasp or to picture out the details of the policies and procedure, like for example, the department, the policy number, the title, and even the dates. Now, also, I want you also to be familiar and at the same time check with me with the contents of the policies and procedure. Maybe there are some correction. At least we can update right away in the quality department to improve our policies and procedure. And to start with, the purpose of this policy is to establish a guidelines to identify, standardize the handling use of HAMS or high alert medication. Now, when we say standardize, this means that our hospital implements a consistent procedure and protocols. And handling, this has something to do with how medications are stored, prepared, administered, and monitored. And high alert medication is defined as these are drugs that bear a heightened risk of causing significant patient harm when they are used in error. Though mistakes may or may not be common with these drugs, the consequences of an error are clearly more devastating to the patient. Now, responsibilities will be from pharmacists, physicians, and nurses. Okay, now before we move on to the policy of high alert medication guidelines and handling, it is very important for us to understand that during accreditation, they don't only check our document, they don't only come to our area with the on-site visit, but during interview, most of the content of the Q&A, it's all about our policy. Now for the policy, it states here that the pharmacy department will provide the general guidelines for proper handling of high alert medications, including a defined list in accordance with the SIBAHE standards. Now, concentrated electrolytes and our high alert medications should not be stocked in patient care areas except as part of the cash cart medication. Then some critical areas may stock limited quantities of these concentrated electrolytes and separate, lock, and properly labeled cabinets away from the regular ward stock medications and closely monitored by the nursing and pharmacy staff. Now, high alert medication must be properly labeled with red warning sticker. This one, the high alert sticker. Dextrose 50% may be stocked for dialysis patient to treat sudden hypoglycemia, and double checking is mandatory prior to administering any selected high alert medications and at time of shift report or any transfer of care. Okay, now moving on to the procedure of the policy high alert medication guidelines and handling. So starting with the general guidelines to reduce the risk when using the high alert medication. So it's stated here that using letter U instead of units in the physician's order for heparin and insulin is not accepted. Then heparin vials should not be placed in the refrigerator to prevent potential mix-up with insulin vials. Then dextrose 50% is allowed to be stocked for dialysis patient as it is indicated for the treatment of sudden hypoglycemia which may occur during dialysis. Then all high alert medication should carry a red warning sticker, high alert. Then we have to focus on this one again, employ independent double checks. This is safety strategy when using HAMS. Also, the independent double check, we said it's a process in which two qualified healthcare professionals independently verify the key aspects of the medication before it is being administered. So we are going to check or verify right patient, right medication, right dose, right route, right time, allergies, expiration date, and pump setting if available. Okay, let's continue familiarizing ourselves with our policy. Moving on to prescribing. It states here that verbal orders are only allowed during emergency situation and telephone orders are not allowed when prescribing high alert medication. Only consultant and specialist should prescribe high alert medications. Now, all physicians must write a daily order for concentrated electrolytes, heparin, insulin, and all narcotic and controlled drug infusions regarding admitted patient. Now, moving on to storage and dispensing. High alert medication should not be stored in floors. Only limited quantity will be kept in separate locked cabinet away from the regular medicine stocks. Then, intravenous anesthetic skeletal muscle relaxant agent should only be stocked in ICU, OR, and ER. Now, each drug should be stored in a separate labeled plastic container. Then, finally, we have narcotic uncontrolled medication should be tightly controlled all over the hospital to prevent misuse, dangerous mix-up, and to be kept in a separate steel cabinets with double locks. Finally, moving on to administration of high alert medication. Now, nurses must double check all high alert medications before administration. Double check is defined here as independently comparing the label and the product content in hand versus the written order, independently verifying any calculation for doses that requires preparation, ensuring the accuracy of infusion pump programming for continuous intravenous infusion medication. Standardized dose calculation table should be utilized for high alert medication on all patient care areas. Whenever administration of high alert medication by continuous intravenous infusion is ordered, a second nurse must verify. Now, currently, we have 14 rights to medication administration, but I want you to focus on these 7 rights. Right patient, right medication, right dose, right frequency, right time, right route, and right documentation. Now, anytime the patient is transferred between units, the nurse transferring the patient and the nurse accepting the patient should check the continuous intravenous infusion of high alert medication at the bedside. The nurse should check for the right patient, right medication, right rate of infusion, right concentration of medication versus the written order. Now, all continuous intravenous high alert medication infusion should be administered via infusion pump. Okay, moving on to the second ESR of the SIBAI, specifically the medication management. So we have here the MM6. MM6 states that the hospital has a system for the safety of look-alike and sound-alike or the LASA medication. Substandard states that there is a multidisciplinary policy and procedure on handling look-alike, sound-alike or the LASA medication. Another, the hospital reviews and revises annually its list of confusing drug names, which includes LASA medication name pairs that the hospital stores, dispenses, and administer. Another standard states that the hospital takes action to prevent errors involving LASA medications, and these actions includes providing education on LASA medications to healthcare professionals at orientation as part of continuing education. Now, in our institution, how do we achieve this one? The academic affairs and training, nursing education in coordination with the pharmacy department. We usually conduct an in-service lectures with regards to improving the safety of high alert medication as well as LASA or the look-alike sound alike, including medication error reporting and the crash cart. Then another, using both brand name and generic names for prescribing LASA medication, writing the diagnosis indication of the LASA medication on the prescription, changing the appearance of look-alike product package, reading carefully the label each time a medication is accessed and or prior to administration, minimizing the use of verbal and telephone orders, checking the purpose and indication of the medication and the prescription prior to dispensing and administering, and then placing LASA medication in locations separate from each other in a non-alphabetical order. Okay, now moving on to another policy that supports the second ESR under medication management, we have the policy on look-alike and sound-alike. So the purpose of this policy is to establish a clear policy guidelines on handling look-alike, sound-alike drugs in order to prevent potentially harmful medication errors that may result from confusing medication names, similar product packaging. Now, as for the definition, LASA is defined as look-alike, sound alike. Now, okay, we have a problem here. Alike medication. This is look-alike medications. Definition is medications that are visually similar in physical appearance or packaging. Another, we have sound alike medications. These are medications that have spelling similarities and or similar phonetics. Then Tolman lettering is defined as practice of writing part of a medicine name in upper class letters or in the capital letters to help distinguish sound-alike medications from one another to avoid medication errors. Now, for the responsibility, this is for the pharmacy head, supervisors, healthcare professionals, and the pharmacy therapeutics committee. So this is an example of a Tolman lettering. So these medications look alike. So we have here the hydralazine hydrochloride and hydroxyzine HCl. So on this side, the ALA is in capital letter while the OXY is in capital letter. So we use the Tolman lettering to distinguish the look-alike medication. Okay, now moving on to the policy on LASA. If you notice, the required standards stated in the ESR of the medication management of SIBAI is also stated in our policy. Like, for example, the pharmacy maintains a list of look-alike, sound-alike medication used in the organization. And then our hospital takes action to prevent errors involving in LASA medication. So what are these actions? So we have here using of both brand and generic names for prescribing the LASA medication, writing the diagnosis or indication of the LASA medication on the prescription. We also have here minimizing the use of verbal and telephone orders. We have checking the purpose and indication of the medication on the prescription prior to dispensing and administration. And then we have placing LASA medication in locations separate from each other in non-alphabetical order, and the list of LASA is posted in all hospital areas involved in the medication process, and all individual who manages or utilizes the medication in any manner should become familiar with the drug listed and should be aware of the potential error due to look-alike, sound-alike nature. Okay, now for the procedure of LASA, it is stated here that the common risk factors associated with LASA medication includes illegible handwriting, incomplete knowledge of drug names, newly available products, similar packaging or labeling, similar strength, dosage forms, frequency of administration, and similar clinical use. Now, our institution's strategies on how to avoid the errors in the look-alike, sound-alike medications, they have provided us some actions. So, our hospital, specifically the pharmacy and the therapeutic committee, shall identify the list of confusing drug names, and they're going to revise and update this one annually. And this list should be posted or must be posted in the pharmacy and all care patient areas. Also, with regards to procurement, whenever possible, they will minimize the availability of multiple medicine strands, and whenever possible, also they will avoid purchase of medicine with similar packaging and appearance. Okay, so we continue with the procedure on LASA. So we have here the storage. So the LASA medications stored in pharmacy and patient care areas are labeled with labels bearing the drug name and have a Tolman lettering and auxiliary yellow label look alike, sound alike, or the LASA. Then next we have to place the LASA medications in locations separate from each other or in non-alphabetical order. Now, with regards to prescribing, writing legibly using both brand and generic names for prescribing the LASA medication, prescription should clearly specify the name of medication, dosage, form, dose, and complete direction. Now, writing the diagnosis and indication for LASA medication on the prescription or order. Then next, we have communicate clearly. So you have to take time in pronouncing the drug name whenever an oral order has to be made. Ask the recipient of the oral communication to repeat the medication name and dose. We came from different nationality and we pronounce words differently. So we need to make sure that we are referring to same thing. Then last, we have minimized the use of verbal and telephone orders. Okay, now moving on to the administration of LASA. So first, we have to read carefully the label each time a medication is accessed and or prior to administration. And then we have to check the purpose of the medication as well as the dose prior to administration. And then we have to double check it with another caregiver before giving or administering the LASA medication. And you can also encourage your client or your patient to question about the medication when it becomes unfamiliar to them. And then moving to monitoring, you have to monitor the new drugs added to the hospital formulary as they are released and provide guidelines to these new drugs. Then monitor patients who may have received wrong medication as a result of LASA medication error. Okay, now moving on to the last or the third ESR of the Sibahe under or medication management. So we have 41. It states that the hospital has a process for monitoring, identifying, and reporting significant medication errors, including near misses, hazardous condition, and at-risk behavior that have potential to cause patient harm. Now, substandard states that there is a multidisciplinary policies and procedure handling medication error. There is also a policy that has a clear and acceptable definition of significant medication error. The treating physician is notified of the medication error at the proper time. Then medication error reporting is completed within a specific time frame after discovery of the error. The hospital has standard format of reporting medication error. The staff are educated on the process, importance of medication error reporting. That's the reason why we added this one in the annual lectures with regards to 41, which is the reporting of medication error. And then there's also an active reporting of medication errors like near misses and hazardous situation. The hospital conducts intensive root cause analysis for all significant and potentially significant medication errors. Medication errors, near misses, and hazardous situation are documented in the patient's medical record. The hospital utilizes reported data to improve the medication use process to prevent medication errors and improve patient safety. Now, healthcare professionals are provided with feedback on reported medication errors, near misses, and hazardous situation. And finally, the hospital reports sentinel events related to serious medication errors to the relevant authorities. Okay, now moving on to the policy that supports MM41, which is the reporting of medication error. So we have our policy entitled Medication Error Policy. Now I want to focus on the definition of term. We have medication error. It is defined as any preventable event that may cause or lead to inappropriate use of medication or patient harm. So a medication error is a preventable, it can be avoided. Okay, now moving on to medication error policy, specifically with the classification of seriousness of medication errors. Now here we have 5 columns: the error category, error occurrence, reach patient, associated harm, necessary measures, interventions, or actions. Now for the category, we have category A, B, C, D, E, F, G, and H. Starting with category A is also known as hazardous situation, error occurrence potential, which means the probability to cause error. Did it reach the patient? No, so there's no associated harm and no necessary measures needed. Next, we have category B. This is also known as near miss. Error of occurrence? Yes. Did it reach the patient? No. So again, no associated harm, no necessary measures needed. Now, category C, D, E, F, G, and H. This category has reached the patient, so it must be documented in the patient's file and necessary measures in intervention is needed. Next, category E, F, G, and H. This is also known as significant medication error. This is any medication error that reached the patient and resulted in a temporary or permanent harm, risk of death, or even death that needs necessary measures. Another category F, G, and H. This is also known as sentinel event. This is any unanticipated event that resulted in death or serious harm to the patient, physical or psychological injury, and not related to the natural cause of patient illness. This also needs an intervention necessary to sustain life. Okay, now moving on to the policy of medication error. It states here that our hospital shall have a mechanism to identify, correct, report, and prevent medication error, near misses, and hazardous situation. That the treating physicians shall be notified of the medication error at an appropriate time. Medication error reporting shall be an non-punitive and strongly encouraged process. That you need to be aware of the medication error reporting website. Then medication error that have reached the patient, like the category C, D, E, F, G, H, shall be documented in the patient's record or file. Now, there shall be an active reporting of the medication error. Then the reported data shall be analyzed and utilized to improve medication use process and prevent medication error and improve patient safety. And the medication error report form shall be completed and received to the pharmaceutical care department within 48 hours after the discovery of the error. Okay, moving on to the procedure of the medication error reporting. It states here that medication error reporting in our institution is a non-punitive and strongly encouraged process that all healthcare professionals, including physicians, pharmacists, and nurses involved in medication use must report any identified medication error, and that all healthcare professionals involved in the medication use are educated on the process and importance of medication error reporting as part of general orientation when joined to the hospital and also as part of the CME lecture. That's the reason why I added medication error reporting as part of our annual in-service lectures. Okay, now moving on to the most critical part of the policy, reporting of medication error. Now, when a medication error is discovered, the following steps should be carried out. Okay, first, any healthcare professionals who discovered a medication error, whether he or she is a physician, pharmacist, a nurse, or any healthcare professional involved in the medication use, must notify the treating physician who must take appropriate action. Next, medication error report form must be completed and sent to the pharmaceutical care department or in the pharmacy, or you can report it electronically using this portal, and it must be reported 48 hours after the discovery of the error. Next, the medication safety officer will investigate to determine the impact of the error of the patient and fill the designated area for the recommendation in the medication error report form, giving suggestion on how to prevent the recurrence of this error. Next, the completed medication error report form is kept in the pharmaceutical care department in a specific file or electronic folder. Next, if the medication error reached the patient, this is category C, D, E, F, G, H, a copy of the completed medication error report form must be kept in the patient's medical record. Then, if the medication error is significant or potentially significant, now the quality department, together with the pharmacy director, medication safety officer, or all required healthcare professional, must do an intensive RCA or root cause analysis to provide recommendation to resolve the problem and prevent the reoccurrence of the error. Okay, to continue. Now, if the medication error resulted in sentinel event, category FGH, the hospital director will report the sentinel event to the MOH within 3 days from the date of event. Now, the pharmaceutical care department must provide healthcare professional who reported the medication error with a written feedback on the reported error. And the medication safety officer will review and complete the medication error report form. Then, the medication safety officer will report medication error monthly to the MOH website. Okay, now moving on to the guidelines to prevent medication errors. So we have here guidelines for the prescribers. Now, the prescriber should write a complete, clear, and unambiguous order that must include drug name, dosage form, strength, dose, route, and frequency or rate of medication administration. Then, the prescriber should use exact metric weight, not the apotential weight of the dosage form prescribed. Then, they should not use vague instruction. Vague means unambiguous or not clear. Then, they should not use abbreviated or unofficial drug names. Then, a zero should always precede a decimal point for doses less than 1 milligram. We term this one as leading zero, but should never follow a decimal point for doses larger than 1 milligram. We term this one as trailing zero. Not following this can lead to a tenfold overdose. Okay, to explain further the concept of leading zero and trailing zero. So example here we have leading zero. So it is correct to write 0.5 milligram. In leading zero, a zero should always precede a decimal point for doses less than 1 milligram. So it is incorrect to write 0.5 milligram because this can be misread as 5 milligram. Now for the trailing zero, we have to write it 1 milligram, not 1.0 milligram because this can also be misread as 10 milligrams. Okay, now let's continue with the guidelines to prevent medication error. So again, we have to write the indication for PRN doses. We have to avoid illegible handwriting, minimize telephone and verbal orders, document drug allergies, and monitor patient on narrow therapeutic index drugs. What are these? These are drugs that requires precise dosing and close monitoring to stay in a safe and effective range. Small differences in dose or in concentration, this can lead to serious therapeutic failure or serious adverse drug reaction. So an example of a narrow therapeutic index drug, we have warfarin, digoxin, lithium, phenytoin, theophylline, or cyclosporine. Then prescriber should not write U after an insulin dose because it can be interpreted as 0 or 4 or CC, causing a deadly overdoses. Then prescriber medication in generic names only except when brand name is required or accepted. So the use of generic and brand names for LASA. Added also in the medication error policy, we also have here the guidelines for the pharmacist. Okay, let's continue with the medication error policy. Now let's focus on the guidelines for nurses. So first, we have to confirm the patient's identity by knowing the name and the MRN number of the patient. We have to check the identity and integrity of dispensed medications. We have to compare the used medications with the doctor's order and medication sheet. We have to verify the unusual dose or volume with the pharmacist. Don't borrow medication from other patients' cassettes. Use standard administration time. Always double check your calculation. Document any administered drugs. We have to double check action rates of critical and high alert medication. We have to label all prepared syringes properly or prepare the syringe at the bedside and administer its content immediately. Do not use product that is not labeled. Do not trust your hearing when receiving verbal or telephone orders because sometimes you may mishear, misunderstand, or mistranscribe the message. Okay, finally, we have to follow the do not crush drug list. Correction, crush, C-R-U-S-H. Okay, I will further explain this one. Okay, so I want to present to you some examples of medication that should not be crushed, starting with aspirin EC. The type of formulation is EC, it means enteric coated. They are designed to dissolve in the intestine, not in the stomach. Crushing destroys their protection. Another example, we have metropolar ER. ER means extended release. So they are designed to release slowly over time. Crushing can cause dose dumping. This is a sudden release of full dose. Another example, we have nitroglycerin SL. So the type of formulation is sublingual or buccal, meant to dissolve under the tongue or in the cheek. Crushing destroys the proper absorption. Another example is the chemotherapy drugs, cytotoxic or hazardous drugs. So crushing can release dangerous dust or particles harmful to caregivers. Then another, we have divalproic sodium. So taste mask or irritating drugs. Crushing may expose the bitter taste or irritate the mouth, throat, and stomach. So we have another common examples of do not crush drugs. So we have nifedipine XL. It means extended release. So risk if crush, we have sudden drop in the blood pressure. Another, we have oxycontin, extended release opioid. Risk if crush, respiratory depression, overdose. Then we also have pantoprazole EC, enteric coated. Risk if crush, stomach acid destroys the drug. Then we also have Adderall XR, extended release stimulant. Risk if crushed, we have overstimulation side effect. Then we also have lithium SR or sustained release. Risk if crushed, we have toxicity risk from a sudden release. Here are some of the documentations during the in-service lectures conducted by the pharmacy department related to the improving on the safety of HAMS, LASA, medication error reporting, and the crash cart.